Happy Sunday.
This meeting
Happy Sunday. Happy Sunday, everyone who's joining. You all are coming in slowly but surely.
Hi there.
Hey. Uh-oh. Nicole, it looks like part of you is outside.
Yes, it wouldn't let me blur the background.
Oh. Technology has its own way of doing things. It's good till it's not. What's going on, Mastermind?
I'm not feeling the
After
greatest.
this, you better be passing this test.
I need to because I'm tired. I'm tired.
But
But
hey, you know my story. Y'all
I
got the
do.
big fight going on in the D tonight. You gonna have to box it up like Clarissa.
I heard somebody say enjoy the fight. I was like, what they talking about? I don't watch
Oh
TV.
my
I don't know
God.
nothing. So it's a
I'm
fight coming
not
on
even
now.
into boxing, but I've been following her on social media. And I said, if I didn't have class tonight, I would have flown on out to Detroit tonight.
Oh wow, I know nothing about it. I know nothing about it.
Right there in your city, huh?
Yeah, didn't know.
My daughter's dad live in Detroit.
Okay.
Mhm. All right, y'all. We have 2 minutes before we start. And anybody know me know that I'm punctual. I think right now it's saying that there are multiple people on the call. Nicole, are you on here twice?
Am I? It looks like it. Yes.
Okay, you are. Okay. One for video and one for audio. Is that what it is?
I I don't really know the answer to that, but
Well, let me see. I see a Nicole Smith. Is that
that's
you?
me.
Okay, and then I see a Nicole. Let me, because if you don't identify yourself, I will have to delete you from the group. So, Nicole, if there's another Nicole on here, would you please show yourself?
You know what? It asked me to put in my name, and I put in Nicole, and then I looked up there and I saw Smith, and I said, okay, that's me.
Oh, okay. So you are on here twice. Is that
I
what
am
it is?
on here twice.
Okay, that's what it is. Do you want to keep
Yes.
both or do you want to take? Okay, there, it just took it off. All right, y'all. So Nicole, I will briefly tell you about who I am. Mastermind and I have worked together before. So I'm Sherry Bogart out of Memphis, Tennessee. And so, just to let you know that I take this very serious, I teach individuals how to. I tell you all, I'm not here to say you're going to pass the exam, but I am going to give you tools, ultimately, tools on top of what Dr. Pam is giving you all to make sure you change your mindset and you can look at this exam in a different light. I'm an LCSW. Prior to, I was a LAPSW. Prior to, I was a LMSW. And I came with my bachelor's in sociology. So I wasn't a MSW, a BSW. So with that being said, when I took my LCSW, I had all odds coming against me, just like we all do every time we get ready to take our test. It seemed like the whole world just falls apart. But on top of that, I probably spent about $20,000. Dr. Pam used to be my tutor, before I finally passed my exam, and it took me 13 times to pass my exam. I'm not ashamed to tell people that because I knew what I wanted. I knew I had to work for it. And now that I've taken it 13 times, I'm teaching it. A lot of my students do pass. I don't charge it to myself. I just say we all, like Dr. Pam say, we talk about equal finality. We're all going to get there. It's just not at the same time. So with that being said, it's just the three of us. So tonight I'm talking about, and others may join, but tonight I'm subbing for Dr. Pam, and I'm going over the DMS 5. And so, as we get into this, I want to make sure you all have time to go ahead and grab pen and paper, or if you're the person that like to type, you can type, You will get this recording, so you can go back and look at it later. If you have not seen the DSM-5, remember it was a DSM-4. The 5 has been out, I think now maybe 8, 10 years. I always tell people I have a private practice, and even in my private practice, I keep this book near me. But I will say you do need to have knowledge of the diagnosis. There's no getting around it, especially as an LCSW. You need to have clinical knowledge so that you can actually, a lot of times you give your clients a provisional diagnosis, but at some point they need that provisional diagnosis to turn into a diagnosis. I also tell people that you should never be top heavy on diagnosis, meaning that at the time that you're assessing your client, what I suggest is when you're assessing them, that you ask them, you should be asking them, so have you ever seen a therapist before? And what was that diagnosis that the therapist gave you? And in talking with them, if the diagnosis tends to meet or kind of touch on the things that's presenting while they're meeting with you, then don't load them with another diagnosis. I work in mental health overnight, and a lot of times I see clients coming in and they got like 20 diagnoses. Oh, Miss Hillary, I'm subbing for Dr. Pam, and I will have to turn shut you, by her standards. I have to put you out of the class until you stop driving. So when you get to a stopping point, just log back in, okay?
Okay, I'll stop. I'm headed from church. It'll give me 15 minutes. I'll be back when I get to the house.
Okay, thank you. And so what we're gonna start tonight is, what do you all know about the DSM? Nicole, I'll start with you.
I just know that it's the manual of the mental disorders. I know that it's changed a lot since I actually used it, because I started out with the 3R, and so I know that a lot of well, maybe not a lot, but some of the diagnoses have changed, and they don't use others anymore, and they changed the names and combined some.
Okay, perfect. Mastermind, you want to add anything?
You said what the question was, what do you know about the DSM?
We can't hear you, Mastermind.
You can't hear me?
It's better.
Okay. So the question was, what was the question? What is the DSM?
What do you know about the DSM, or what do you want to share about your knowledge regarding the DSM?
It's just a manual that we use to diagnose. This is the manual that, for me, that's what I use in order to build insurance companies.
Okay, perfect. Miss Jones, thank you for joining us. If you're not aware, and Miss Jess, thank you for joining us. I'm Sherry Bogart. I'm the sub for Dr. Pam tonight. I've been her sub for a while. Some people know me, some people don't. So thank you all for joining. Tonight we're covering the DSM-5. You haven't missed a whole lot. We're actually just starting. But remember, they will send you this recording. If you don't get it, just contact Academic Coaching at that email address, and they can send it to you. So I just suggest everybody grab pen and paper tonight, and do know I call on names. It's not picking on you, but that's the best way to learn. So we're going to first start with the components and functions of the MSE, which the MSE is the mental status exam. These are used like in nursing homes and hospitals and things of that nature. And the goal of it is so that you can create a SOAP. So Miss Jones, what is a SOAP? She like, already?
I was thinking that too. So a SOAP, like a SOAP note, like the subjective, objective, is it assessment?
There you go.
And plan? Is
there
it
you
planning?
Go.
Okay.
Girl, don't second guess yourself. That's it. So we do SOAPs as licensed clinical social workers and even as non-licensed, and just period. We're always collecting that information. The subjective is when a client is coming in telling you about what's going on with them, but also in your MSE, alongside with the MSE, while creating that SOAP, you're also looking at them. So, you have clients that come in, sometimes they can't talk, contingent on what their diagnosis is at that time. If they're in a catatonic state, they're not going to talk to you because catatonic means they at a standstill. So with the MSE is going to collect that information. You're looking at their appearance. When I worked for Department of Children's Services some time ago, we used to have to gauge people's body, like to see if they had tattoos in various places. You have to look at kids and see if they have scars, and you should know if the scar look like it's healing or if it's fresh. So things of that nature. So you're gathering the appearance, you're calculating if it's a male, is it a female, are they Asian, African American? And these are things that also used in your psychosocial assessment. So you're looking at the appearance. If your client, you've been meeting with someone for a year and they first came to you, they was 200 pounds, and then 11 months later, they're like 150 pounds, and you can see it, you need to be assessing it. And assessing is just asking questions. So you say something like, Miss Bogart, so what's going on? It appears that you're losing weight. And your clients will be honest with you. If their clothes are clean, if they're dirty, if their hair is all over their head. Now, one thing we also have to know is we are not to assume anything. I do home visits occasionally, and I go into some homes and they're not clean because a person just not able to clean it. But there are some homes I'm like, yeah, this warrants a DCS referral or APS referral, things of that nature. So don't be judgmental and assess why the home isn't clean. And so that same thing applies to a person's appearance, because to you, a hairstyle may mean that you go to the beauty shop every week. My hairstyle may mean that I just have my hair all over my head. So if that's just something that applies to me, then that's what's going on. Hey, Cassandra, thank you for joining us. So you're also going to look at the behavior. You want to assess them to see if they're sweating while they're in your session. You're looking at if they have rapid eye movement. That means they might be high. If their speech is slurred, things of that nature. So let me keep sharing. Are you all able to see the screen? And then you have the mood, also known as the affect. And this is where the person is, you're looking at how they're feeling. You want to make sure that the mood is actually congruent with everything else. So, you don't want somebody giggling the whole session, but they look flat. It just doesn't match. So, in essence, that's what your MSE is. And I'm starting there because it's important to know that the mental status exam plays a big role in when you're doing diagnosis. Now, what I shared at the very beginning of the call is that it's very important that you understand diagnosis. You're not going to know all of them. And it's also important to keep a DSM by your side. Or now we can Google everything. But I like to go to my book because sometimes Google can add its own stuff. However, with that being said, just to recap, Jess, what are the things that you're going to look at? You can read A through F. Okay, I don't think Jess can hear me. So, Nicole, just to recap, read A through F. What are the things we're looking at when we're doing a MSE? We can't hear you, Nicole.
I don't see A through F.
Yeah, I don't see
anything either.
Yeah,
Oh, y'all been let me talk the whole time and I
well,
said,
I see MSE and the numbers, but I don't.
really?
Yeah.
Okay, hold up. Thanks
Yeah,
for
I'm looking at like your files.
let's see.
Okay.
Okay, is it showing now?
Yes.
Yeah.
Okay, thanks. So we'll show on our
And
end.
so their appearance, their appearance. I'm looking at how they're dressed, if they have scars or marks, tattoos. I'm looking at their attitude and behavior to see about congruency with their affect and how they're positioning their body, and looking at their mood and affect as well, for congruency, and um, noting their speech, maybe the speed of their speech. If there's pressure in their speech, and their thought process, to see if they are able to follow the questions that I'm asking, or if they're able to give me clear answers, or if they are avoiding answering
There
questions.
you go. Thank you, ma'am. And so there's other things. This is the time where you do the assessment. Are they alert and orient times three? Jess, what is times three?
Times three, is that when you're saying like place, location, and date?
That's correct. And occasionally we used to say, so what's today's president? So
Yes.
those are things you're looking for as well. And remember, you still assess the whole time. You're asking them questions, and they really will be honest with you. Now, once you complete your mental status exam, you should be able to create a summary. And your summary will look like this. Asia, read the summary where it says a paragraph about mental status.
Okay, so the client is 43 years old, that one.
Uh-huh.
Okay. So a client is 43, oh sorry, a client is 43-year-old woman who looks older than her stated age. She is well groomed and appropriately dressed for a professional interview. She is well oriented. Her speech is slow, as if it is painful to talk. She has had occasional thoughts of ending it all, but has not made any suicidal plans or preparations. She talks about future events with expectations to be alive. She is aware that she is depressed and recognizes that the source of some of the feeling comes from inside moods. Although she often refers to the difficulties of her situation, her thoughts are organized. She is not psychotic.
Okay. So are you all doing this in your typical day-to-day job? Sort of, kind of, yes, no? Okay.
I work for a hospital as an inpatient social worker,
Mm-hmm.
so our biopsych assessments do have components of this, but not
Mm-hmm.
all.
Okay.
The residents or the doctors will have something that's more like this than what I
Okay.
would rate.
Okay. Perfect.
And
So,
in
uh,
my work, I work with the Texas Department of Criminal Justice, and I'm
mm-hmm.
a staff victim advocate.
Mm-hmm.
So I don't necessarily see my clients face to face. It's a text
Mm-hmm.
message. If they're if the inmate has thrown waste on them or spit on them,
Mm-hmm.
depending on where it lands, I reach out to them.
Mm-hmm.
If they've been assaulted, I reach out to them. If it's a aggravated assault, then I want to actually talk to them, and then I have another person who's probably in that city who I will contact them and ask them if they will go and lay eyes on them just to tell me what they see.
Okay. So we often thank you all for sharing that. We often say don't take the test the way you play at work. But if you've never seen an MSE in summary, this is how it looks like. And in essence, what you are doing is capturing a person from head to toe during the entire time that they're sitting with you. And it should not exceed more than 5 sentences. After, you just capturing their demographic, their sex, their race, their age, how they're presenting in the session, how they're talking to you, things of that nature. Anyone have questions, comments, concerns about that? Okay. So some common test areas, these are also things before we get into the meat and potatoes of the DSM. When you are actually giving people diagnosis, you're using tools as well, which are like the achievement aptitude test. And so the achievement aptitude test, basically, and I'm just reading it, it's education. When you hear the word achievement, the first thing pops up in your head should be education. And what this does is measure how the client know, you can see how they're achieving and their progress in their learning. And a lot of times, this is a test that we take before we even go into elementary school or before we enter into high school and things of that nature. I know they used to do it. I don't know if they still, I think they still do it. They have to, it's mandated. Um, and then you have the intelligence test. That's how we get our IQ. Again, our IQ is given to us like when we're small, when we're first entering. That's why they put us in elementary and we used to bubble on the paper. If y'all, now I'm probably telling my age. Did anybody used to do the bubbles? Okay. Okay, that's good. I thought I was telling off from my age over here, but you're doing the bubbles. But right now they have the kids doing everything on computer. But this is how you get your IQ to say if you're 70 or above or 70 or below. And then you have your job, your occupational test. This is when we're getting ready to go out into our careers. A lot of times this is either when we're graduating from high school, they do this around your junior or senior year, and sometimes they do it your junior and senior year of high school. But it's just to kind of see where you are going in your career. And they actually do this with kids who have IEPs. It is actually mandated. Did y'all know that? Yeah. And the reason is because students with IEPs have to have special situational places, things in place after the life after high school. And so they're testing them because a lot of times they're not going to college, but they got to be able to place them. If they're functional enough to work, they say, okay, this student may be able to work at Amazon. This person may be able to work at Walmart as a bagger. They may be able to work at Amazon if you put them on an assembly line where they can just pick up stuff and put it in a box. So that's how you do that occupational test. And then we have the personality test. And this is something we're really doing with our clients a lot already. When we come, all of us have a personality disorder. And a lot of times when your clients come to you, that's when you see the things like borderline personality disorder. You see obsessive compulsive personality disorder, not to be a personality disorder, not to be confused with OCD. And so that's another reason why we have to know, in essence, what the diagnoses are, because some of them look alike, and we have to be able to say this is exactly the diagnosis that I'm giving my client. And then you have the neuropsychological test, and this just focuses on like if there are some issues. So like if somebody comes into the hospital and they had they was in a car accident and there was a brain injury, then the neuro is doing tests to kind of see where the brain waves are and identify if the person lost memory, is a short-term memory, they're having issues with long-term memory, things of that nature. And then you have the specialized clinical tests. And this actually assess anxiety and depression. Has anybody heard of any of these tests before? Okay. Have y'all seen them up practice questions? Nicole, did you have a question? You on mute.
Come on. I'm sorry.
Okay.
I used to work in behavioral analysis services in the military. And so a lot of these different tests we would give to the students to decide whether they should be returned to duty or whether they should be returned to their home.
Yep. They're critical in our day-to-day world. Again, I use real life examples. Sometimes I fix them up a little bit for the sake of my clients. But when I tell you I use probably all of those tests because it really helps me facilitate and be able to give the proper diagnosis. So anybody have any questions, comments, or concerns before we go to the next item? Okay. So what I'm about to do now is just assess you all. Everybody will get a test question. Let me make sure I blocked out the answers. I bet I didn't. Okay, y'all, just 1 second. I'm gonna be trying to cheat, y'all. Okay. I'm gonna stop in it. I'm going to take it down. Just 1 second. Let me block out the answers real fast so y'all can't see them. Mastermind, are you still on here?
Yeah, I'm here.
Okay. So I need to make sure. I think it's 6 of us on the call then. Block them out. Y'all remember these are practice questions. And so don't get caught up in them. Everything that I share with you all tonight, you will get a copy of. I'm just blocking out these answers real fast. I thought I had did it. I apologize. Okay. Now I can share. Let's see. So this is how you're going to read your questions in this order. Let's see. Nicole, you will be first. Asia, you're next. Jess, Cassandra, Nicole, Asia. Somebody move. Jess move. Jess, Cassandra, and then Mastermind. So here we go. You all literally have 2 minutes to read your question. You can read, you have to read it out loud. And then if you want to read it a second time, you can read it to yourself. You're going to eliminate 2 if it's 4 choices and keep 2 and then go absolute to what you think the answer is. If it's 3 choices, then you're only going to eliminate, you're still going to eliminate 2. I hope you all can see this. I'm trying to do the best to make sure everything shows on this screen. All right. Who's first?
Where are the questions?
They're not here.
No.
Ah, this is starting to pee me off. Yeah, I'm trying to stop. I said this year I was not going to have a potty mouth, but it's been so much happening. Is it on here now?
No.
Still not. Somebody said, well, I don't want to do questions, and the Lord answered your prayer. Let's see. Um,
All right.
okay, it's showing now. Okay, perfect.
Yes. All right. A 42-year-old man presents with auditory hallucinations, anhedonia, and depressed mood for the last 4 months. He reports hearing a voice calling him worthless. There's no history of mania or hypomania, and hallucinations only occur during depressive episodes. Which differential diagnosis should be considered first alongside major depressive disorder with psychotic features? Oh, wow. I do not know the answer, but I'm going to go get rid of schizoaffective disorder.
Okay.
I'm going to get rid of B, persistent depressive disorder. I'm going to go with bipolar disorder because of the
Okay.
hallucinations, the depressed mood in the last 4 months.
Okay. What's anhedonia?
I don't remember.
Just take a guess at it.
What is it?
Anhedonia, this word right here.
Yeah, I don't.
Anybody want to help her?
Is that when you can't experience pleasure?
There you go. So what is anhedonia, Nicole?
Not experiencing pleasure
Okay.
in any
And
activities.
And I'm telling you, so it's always important to know words within the content because sometimes it helps us engage, it helps us gauge and process. But you did good. Let's see. You said what you said you thought the answer was?
Bipolar disorder.
Bipolar disorder. Let's see. Um, so I'm gonna let you read it, Nicole.
Schizoaffective disorder. Schizoaffective disorder should always be a differential diagnosis consideration when psychotic symptoms are present with major depressive disorder. Wow, this case is most consistent with MDD with psychotic features because hallucinations occur only during depressive episodes. Clinicians must rule out schizoaffective disorder by confirming there are no periods of psychosis independent of mood episodes. Schizoaffective disorder involves both mood disorder symptoms and schizophrenia symptoms, including psychosis, so it is the most likely differential diagnosis for major depressive disorder with psychotic features.
And you can stop there.
Okay.
So, do you think you understand what schizoaffective is? Because schizoaffective is something that often looks like schizophrenia. And so we really have to be able to differentiate. So, I want to ask you, I know you probably can't say it just right now, but do you feel like it makes a little bit more sense?
No, because I don't understand what it is.
So you never heard of schizoaffective?
Well, I have, but I'm thinking of their face, their features, their affect.
Mm-hmm.
Um, but yeah, I don't know anything about the diagnosing like this.
So just remember with schizoaffective disorder, you're going to make sure some of the things you have to remember within the disorder is major depressive disorder, MDD is there. And again, this is one of those where it's called differential. You have to know because it has a time frame to it where after it skips from this, then it goes to schizophrenia and things of that nature. So the major depressive disorder is one of the major features as well as some psychotic features that you're going to look for in it. But you will have access to this question. Does anybody have an issue with schizoaffective disorder?
No, but I would like for you to explain differential diagnosis. What does that mean?
So differential diagnosis, just say if your client came in and they're presenting as with low effect. They look like they zoomed out. The things that they tell you is that I'm not sleeping well, I'm overeating, things of that nature. Now, it could be that they're at their lowest point when it comes to schizophrenia. But you can also be like, well, these are symptoms of depression. So you got to be able to differentiate between the two so that you give the accurate diagnosis. I put it in simple terms, but did it make sense to you all?
Yes, thank you.
Anybody else have questions, comments, concerns? Okay. Who's next?
There we go. A client who recently lost housing and has bipolar disorder needs rapid support. The social worker begins drafting an intervention plan. What should guide the selection of interventions? So we have A, what worked for the last client with bipolar disorder? B, the client's immediate safety needs. C, recommendations from the social worker supervisor. And D, evidence-based tools. I gotta read this to myself one more time.
Okay.
Let's see. I don't know what I should rule out.
I just rule out two, Asia.
Okay. Let's see. So I would probably rule out C,
Okay.
recommendations from the social worker supervisor. And then I will rule out, because if we're in the intervention stage, we should have already did safety needs,
Okay.
I would assume. So I would say I'll rule out B.
Okay.
And then I don't know, I think I got it wrong, but I think I would go with D.
D like dog?
Yeah.
I'm a dog fan, so I'm gonna say D like dog. Let's see. My computer is not acting right. So I'm gonna let you read it.
Okay, the client's immediate safety needs in the situation is given the client has lost their housing. This represents a potential crisis situation in which immediate safety needs should be the priority. What worked for the last client with bipolar disorder may not be effective for the current client as individual assessment and interventions are warranted. Recommendations from the supervisor may be helpful should the social worker require guidance, but this is not the centerpiece of the chosen intervention. While it is always important to choose evidence-based tools, safety is essential in a crisis situation.
And so
I
what
think
did
I
you
rushed
say,
through that a
April?
little bit.
There we go. I wanted you to see. It was right there. It said lost housing. Who wants to
And I
talk to you if they don't have housing?
right. And I don't know why I went straight to like I always do that. 'Cause I took the test and I missed it by like 3 points. And I'd be second guessing myself. I read too fast.
You're going to get there.
So
That's why you read it twice. And so
mhm.
just remember, you all, in a question like this, and it also said, you was like, they already did the intervention plan. It didn't say that. It
Oh, it
says the
didn't.
social worker begins drafting an intervention plan. And I know I heard you say they already did it, so they already addressed safety. And so that's the thing. Remember, in that when you talk about the social worker planning process, you have the assessing. And when you're assessing, you're looking for safety, and you're acknowledging their feelings. Nobody wants to talk to you if you skip over the primary thing. And so that's why housing is a safety issue. If they're not placed in a house, then they're on the street, and that brings up safety. Anybody have questions, comments, or concerns about that? Who is number 3?
I think it was Jessica.
Okay.
I know I'm after her, so
It's not showing all my people. Jess, are you on here?
I am. Thank you, because you had told me that the order switched, so I didn't know where I went.
Oh, okay.
So I'm number 3 then?
Mm-hmm.
Okay. A 38-year-old man has hypervigilance, irritability, and intrusive memories for 3 weeks after a workplace accident. Which differential diagnosis should be considered alongside acute stress disorder? B, adjustment disorder.
Did you rule out?
Well, in my head, potentially, I don't necessarily think it's an obsessive compulsive disorder. I don't see anything ritualistic about it.
Mm-hmm.
And schizoaffective disorder, I'm not sure where that would fit in.
Okay.
But an adjustment disorder, it kind of is like a catch-all.
Mm-hmm. And so I'll let you read the rationale.
It is adjustment disorder.
Mm-hmm.
Uh, thank you.
Uh-huh.
Adjustment disorder is a diagnosis when a person shows an extreme reaction to a stressor. This may be appropriate differential diagnosis for acute stress disorder if a workplace incident did not arise to the level of being a traumatic
Hey,
incident.
Jess, where you see incident at?
Maybe an appropriate differential diagnosis for if a workplace accident, sorry,
Mhm.
did not, sorry, I was never really good at reading when
It's
when we
okay.
went
It's
around.
okay. I'm
um,
messing with you because it be typos on this too. I apologize.
didn't arise to the level of being a traumatic event, like no exposure to sexual violence, serious injury, or acute threatened, actual threatened death.
And you
Well,
can stop there. You can stop there
okay.
because you actually already went through them. And so what adjustment disorder is something comes on acute. What is acute, Jess?
It's something that happens in the moment, within days or hours after the incident.
Mm-hmm. 90% of your clients, I'm gonna say more like 80% of your clients in the real world, they're coming to you because something acute happened. There's an adjustment. They just got married, they just had a baby, so now they're going through postpartum depression. They got married and now they got to figure out how to share things with their spouse. They just found out their child is autistic, who is now 5. And so that's what that adjustment look like. And it is very stressful. This is something that really, it could take a long time. It could take you a whole year to have to work with them. It could be less. But keep in mind that this could be confused with post-traumatic stress disorder. So that's where the differentiating piece comes in again. So questions, comments, or concerns?
Question, because I would thought that post-traumatic stress disorder would, I think, be a period of 8 or more weeks.
It is, but
Okay.
some people, when you're not reading questions and they throw in that post-traumatic stress disorder, guess what you could potentially answer?
Well, post, but I
There
just
you
picked.
go. So that's
Okay.
why I'm glad you brought that up. Looking at the time frame, acute just came on, post-traumatic is a long length of time. So keep that in mind.
Thank you.
Uh-huh. Who is it, you, Cassandra?
Yes, ma'am.
Hey, Cassandra, y'all. Cassandra dumped me. No, I'm just messing with you.
Not
I'm just messing
true.
with you, Cassandra. I'm just messing with you.
Not true.
You better get this right, Cassandra.
Oh, Lord. Okay.
And I just
I better. Okay. A social worker drafts a program evaluation report filled with jargon and acronyms that community members cannot understand, despite them being commonly used among social workers. As the supervisor reviewing the report, what is the best feedback? Okay. So I got a social worker. She's doing a program evaluation. She's using terms that really only social workers understand. Um, and then you're the supervisor reviewing the report. So the question is asking, what is the best feedback? So A says make corrections for the social worker and show them the corrections for the sake of learning. B says instruct the worker to rewrite the report in clear, accessible language tailored to the audience. C suggests the worker add more detail and data to show thoroughness. The first one I'm going to rule out is A. We don't want to do the work for the social worker as a supervisor. And that leaves me with B and C, where the social worker is either instructing the worker to rewrite it in clear, accessible language, or add more detail and data to show thoroughness. So I think I would rule out C, to add more detail and data to show more thoroughness, and more so because it's a program evaluation, you're working with the community, so you're working with the members of the community. So we want to make sure that it's clear and they can understand it, understand the report so they know what's happening in the community. So
okay.
let's
Let's
take
see what the answer is. There you go. Go ahead
it.
and give us the explanation.
Instruct the worker to rewrite the report in clear, accessible language tailored to the audience. Reports must be clear, audience appropriate, and professional accessibility ensures the report fulfills its purpose. While social workers may understand the jargon in the report, it's important for the language to be understandable to the stakeholders in the community. More details may worsen if clarity is not addressed. Rewriting the report for the worker will prevent skill development. So it's best to so this isn't the best approach and option.
Okay. So with that, Cassandra, how are we supposed to talk to our clients? On what time, what kind of level?
We're supposed to meet them where they are. We're supposed to talk to where they can understand us. So if we're using big words and different things like that, that we're not relatable, and that can be intimidating.
Mm-hmm. So
So
remember, we are the professionals. So we look, like you say, intimidating to our clients. And remember, the Code of Ethics really wants us to talk to all of our clients on the third grade level. It's just across the board process. So because a person comes in and they're like a doctor, and you're like, oh, this doctor, I can use these big words with the doctor. You're going to talk to the doctor the same way you would talk to a janitor that came to you for support. Questions, comments, or concerns behind that? Okay. Is it you now, Mastermind?
Yes, ma'am. A 40-year-old woman reports intense fear of gaining weight, significantly low BMI, and distorted body image. She engages in food restriction, but does not ever binge or engage in behaviors like excessive exercise or laxative misuse to rid herself of excess calories. Which of the following diagnoses is most appropriate? So you have a 40-year-old woman, and she has some intense fear of gaining weight. Although her BMI is low, she has a distorted body image, and she restricts food, but she never binges. Um, and it looks like she never engaged in like excessive exercising or using laxatives to get rid of calories, and they want to know what is the most appropriate diagnosis. All right, so we have avoiding restrictive food intake disorder, bulimia nervosa, and anorexia nervosa. So I know for sure I can take out bulimia
Okay.
because I believe bulimia is when there's vomiting associated with that, right?
Mm-hmm.
Okay. All right, so I go back to the question between A and C, avoidant restrictive food intake disorder and anorexia nervosa. A
You going with
40,
C?
no, I'm reading the
Oh,
question again. A 40-year-old woman reports intense fear of gaining weight, significantly low BMI, and distorted body image. Okay. She engages in food restriction, but does not ever binge or engage in behaviors like excessive exercise or laxative misuse to rid herself of excess calories. Which of the following diagnosis is most important? I mean, most appropriate. Okay, so I'm gonna go with C.
okay. You are correct. And I want to say this before I reveal it. I know two additional people joined the call. And so I'm going to stop at the questions here, but we will come back to some questions. Mastermind, I'll let you read this because we're going to get into the lesson. And then when we come back to the additional questions, the other two who join the call will be able to do those. It's kind of wonky, but Mastermind, you can go ahead and read it.
Anorexia nervosa involves food restriction, body image disturbance, and fear of weight gain. These match best with the decline in the given description, so a diagnosis of anorexia nervosa is most appropriate.
And you
Believe,
can stop there. I
okay,
do want you all to know that this is a diagnosis that's been around forever. It is increasing drastically. There's a lot of centers opening up across the world. I know there's one about 3 hours outside of Memphis where I live. And the individuals, they manipulate people. Boy, it's bad. A lot of times it's women, but it's starting to increase in men. So for the sake of the test, you will see it applying to women a lot. Pay attention to their word food restriction because they're so afraid to eat. They have this distorted body image where you can literally see they look like a skeleton, like the skeletons that they used to have in our science classrooms. But you cannot tell them that. They swear by the Bible that they are way, way bigger than that. So questions, comments, or concerns?
Was that one kind of like trying to trick us up by using that food intake, food restrictive? Like it was in the
Mhm.
sentence, so it was kind of
Mhm.
confusing because my first thought was like anorexia. Then when she, read it again, I'm like, okay, they said food, restriction or whatever. So what is it when it's food restrictions? Like, is that a diagnosis or is that to throw us off?
So in let me see if I can pull that back up real fast.
If you can, it's okay.
What I wanted to share, I wanted you to see it, but what happens is food restriction, they're still going to eat,
Hmm.
but they're restricting what they eat. Whereas you have other people, they have food restrictions as well in the other two, but one is going to throw up the food. The
Okay.
other one is just going to avoid, they like read everything on the back of the box. So they're avoiding foods that would probably give them the things that they need. So believe it or not, everything that was like in the first two sentences, those was your qualifiers. Everything that fell after that, it was just your distractors.
Okay.
Because again, when it comes to diagnosis can have a tendency. It's going to always be two diagnoses. It's going to look similar, and you have to know that one little cue word to say, this is this versus this.
Okay.
Did that make sense?
Hmm.
Okay. Please tell me y'all can see something that say risk factors versus protective factors.
nope.
Oh,
Can see
Oh,
it, but it's no
wait. Yes, I
question.
did.
Yeah,
Yes, I
I
did.
oh,
see a
y'all did. Oh,
bio.
okay.
I'm sorry.
I'm like this, boy. So I'm about to go ask my kids to go buy me another computer. They gonna laugh at me though.
Okay.
Okay. So on the risk factors versus protective factors, again, this is part of the DSM in the sense that you have to understand when you're talking to your clients, again, your clients are coming to you because it's something going on. And as a licensed clinical social worker, you have the capability of giving them a diagnosis. So you want to ask them what are things that if they come in and like the anorexia question we just got through talking about, that's a risk factor because that person is putting themselves at risk of a lot of health issues. When you become that small, you can end up having kidney issues, having infections, you can end up with jaundice. It's just a lot of stuff. So when you're looking at your protective factors in a sense like that, and it's hard coming out of anorexia. It's just really hard. But they may have a protective factor. Just say if they have a child, they may say that my child is my protective factor. Do anybody want to take a jab at why a child would be considered as a protective factor for a woman with a diagnosis of anorexia?
I would think that, if something happened to me, who's gonna take care of my baby?
There you go. There you go. Absolutely. Did everybody hear that? So this is, those are things you're looking at. The risk, a protective factor could be religion. It could be you having children. And the religion is in the sense of, I'm not going to commit suicide as bad as it is, and I don't want to live anymore, but I'm not going to commit suicide because my religion frowns upon that. So it's things of that nature. Another way you can look at risk versus protective factors is just like this. And so with this being said, your protective factors, again, are the things that's going to make you want to do better. So if somebody comes in with a diagnosis of depression and they give you the protective factors of, I really love my job and da 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 da. So if they really love their job, they are going to do better at pulling out of this depression. They would take their medication. They'll learn coping skills so that they can get up and go to work instead of laying in the bed all day long. Now, a risk factor would look like they're coming in and they're like, you know what? I don't give a care about nothing anymore. I have wrote out my will and things of that nature. I'm leaving stuff behind. And so you have to start assessing and asking questions because those are cues that that individual is probably about to move forward and take their life. So question, comments, or concerns? Has all of you had a suicidal training in the last year? Okay. It's required in the state of Tennessee that we have to have a suicide training, CEU training at least once a year. Oh. So we are about to go into the next section. So Hillary, what is a protective factor?
Sorry, I had to unmute.
Okay.
Um, Protective factors are anything that we can use as basically a patient's strength
Mm-hmm.
um, when they're in crisis situation,
Yeah.
something for them to build on.
What about those risk factors?
Those are negative um, connotations that really are, what I say, factors are that shows no positive influences that they're actually preparing for a
Mhm.
negative situation in their life.
Yep. There you go. So before we get us still into the meat and potatoes of the DSM, thank you, Hillary, for sharing it. We have our defense mechanisms. These play a really vital part in how we also look at our clients. Lying rarely shows up on the exam. Rationalization shows up a lot. And this is one that we often struggle with. Anybody want to be honest and say they struggle with rationalization?
Yeah, I had a practice question wrong, and then when I read it again, I was like, oh, duh. Like I first answer I got it wrong. Then it was like,
Mhm.
yeah, they're rationalizing. So
Yep.
it seems like denial. So that's what I put. It was like, oh, they was like it was something, but it was just basically like something that happened, but so I was like, oh, they're in denial about what happened. Clearly, they
Mm-hmm.
was rationalizing, like, oh no, if such and such, then I would have, you know what I'm saying? So it sounded like denial to me, but then when I reread it, I'm like, okay,
Mm-hmm.
yeah.
Thank you for sharing it. And it's that piece of us that's been hurt. So it's been like, we'll say something like, I really didn't want to be a LCSW anyway, so I don't care that I missed the exam by 1 point. Have anybody said that after they didn't pass the exam? Because I know I said it. I said it a few times. I can't be like, girl, you want that exam. Shut up. You're just saying it because it's when we get hurt. And that's that guy that said, I really didn't want your old funky buddy anyway. I just was trying to be nice to you because you was looking sad or something. So remember, you have to be able to pull that piece out of it. Somebody got hurt, and so they're saying something to try to make themselves feel good. Regression is another one that shows up on the exam a lot. Anybody have problems with regression? So regression is one of these components that actually shows up like if somebody have they have a 8-year old, I'm just well maybe a 6-year old, and then they end up bringing a new baby home, and then they come to counseling family therapy and they say, well, my 6-year old now walks around all the time, and he used to be so independent and did everything on his own. Now he wants to sleep in the bed with me and da 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 this and da 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 da. So that kid is regressing because it's another baby in the environment, and they see what the baby is doing to get attention. They see the baby is in the bed with mama when the baby cries, so the 6-year-old start throwing temper tantrums and things of that nature. So do anybody need any other examples for regression? On the exam, you may also see an adult going backwards, like something may happen that triggered them on the exam, and they end up regressing back to a younger state in their life. And they're doing it for the sake of protection. Denial. Denial is often used for an alcohol and drug question, more so alcohol. And this is showing up where you know for sure the person is an alcoholic on the exam, but they're like, I only drink 2 beers a day, and I don't be drunk. I just be sitting there. But they think I'm drunk. So anybody having problems with denial? Okay. Suppression. Who wants to be bold and tell us what suppression is? Jess, you raising your hand?
I can read.
Okay.
Uh, Suppression. The person is aware of the unacceptable desire and validates it by intentionally tries to keep it from expressing itself. For example, I know I'm an alcoholic, so I'm gonna go on the wagon. A homosexual who intentionally doesn't date members of the same sex so that the unacceptable does not express itself. The introvert is conditioned to be an extrovert. He often suppresses anger.
So that's what your suppression is. In essence, somebody is putting away their real self in order to put on this facade. Also, what you see in suppression is a lot of individuals that's faced with some form of trauma. They suppress their feelings, their thoughts, in order to try to navigate through day to day. Anybody having issues with suppression? Does anyone have issues with projection? Okay. So projection in essence is I don't like my hair, and I come and say, Cassandra, I see you looking at my hair. You don't have to look at my hair like that. And you're like, what are you even talking about? So I'm really projecting my feelings on Cassandra. It's the way I feel about myself. I really don't feel good about myself. So I'm trying to say that Cassandra looked at me and it just cued me off to say she's looking at my hair. So keep that in mind. So the defense mechanisms again, lying is not showing up on the exam a lot in the vignette. It may appear to be like an answer, and lying can sometimes look like denial. But you have lying, rationalization, distraction, regression, repression, denial, suppression, and projection that shows up on the exam. Occasionally, you'll see idolization. And does anybody know what idolization is or not?
I see intellectualization a lot, and it always has me in a chokehold. So,
You've been seeing it on your practice test a lot.
I've seen it on my test. Yeah.
Ooh.
Well, when I was getting my LS, I seen it on the test every single time. Um, and it's always one, and I'm like, I cannot remember what that means. I'm not saying it was the answer, but it was the answer choice.
Was it?
Yeah.
That one normally doesn't
Anybody
show
ever
up.
see that? Because I definitely seen it.
Yeah, I've seen it. I've seen it.
Yeah.
So where are you getting tricked up at?
I don't know. I just be forgetting what it means.
Break the word down.
Intellect,
Uh-huh.
intellectualization. I don't know.
It
Um,
deals with your emotions, but what
yeah.
type of
Well,
emotions?
intellect. Yeah.
What
So
type of emotions is it trying to avoid?
trying to avoid
Mm-hmm.
your intelligence. Yeah, yeah, yeah.
Uncomfortable emotions.
Mhm. Oh, okay.
So,
I know what it is.
mhm.
So
So let's
it's
go
basically
for it.
like
Break it down. Break it down for me.
I think I understand, but I think it's like you're trying to basically you're trying to avoid feeling. So like you might feel
Mm-hmm.
sad about a breakup or your some childhood trauma, whatever. So you're trying to avoid that. So you're trying to basically not deal with your feelings. So basically,
Mm-hmm.
oh, I don't want to talk about that, or
And
oh,
hop onto something else.
yeah, change the subject. Yeah.
Does it make sense now?
hmm I
Okay.
remember it always in the moment, but I think talking about it out loud with saying an example will help it stick with me. And it's probably won't be on the test when I look at it next time, but just in case I know what it means.
There we go. So now y'all know another word that's on there. Thanks for sharing it too.
Yeah.
Well,
Um,
before we move on, intellectualization, I think I'm saying it right.
mhm,
Sometimes it doesn't, the answer is not like, well, the question doesn't say hop from one thing to another. It'll give like something of uh somebody lost out on some money. And then
mhm,
they'll overly explain or overly analyze like how they lost the money. And it's between rationalization and intellectualization. And I think that that's why both of those get confused sometimes. Because with intellectual, that it is like completely avoiding it, but then it can sound like
mhm.
rationalization when they hit you with one of those hard questions, if that makes sense to
It
anybody.
makes sense because they both are focused on emotions.
Mm-hmm.
So with rationalization, our feelings got hurt about something. So what we do is say, well, I didn't want it anyway. So it really didn't matter to me. Whereas with intellectualization, because I can't say it either, but you know what I'm trying to say. But with that, we're gonna avoid it altogether. It happened. I'm going to avoid it and I'm just going to talk to somebody else. So I come home and say, oh, I failed my LCSW exam for the 12th time. And my partner say, well, let's sit down and talk about it. And then I just jump on some other stuff. I delay or I ignore or I start saying, well, you know what? They just got their test rigged anyway. I read the statistics and they said black women don't pass the test anyway. So does it kind of make sense what I just said?
Yeah, that makes sense. Perfect sense.
I thought
Yeah.
I was being for
So
real.
you just gonna go to the facts. I read the statistics, and so you just gonna avoid it. I'm not gonna talk about it, and then you really try to navigate. But again, with rationalization, my little feelings got hurt. I didn't pass the exam. I acknowledge that I didn't pass the exam, but I'm gonna put like a little lie in there, like, oh, you know
Mhm.
what? I'm just taking it anyway because my boyfriend paid for it. I didn't pay for it. It sounds
Okay.
alike, but it's different. And I want to make sure
Yeah.
I made it clear, but did I make it clear?
Yes, you made it clear.
Okay. Oh, let's see. Anything else you need to know about this? Okay. So we're going to come off of that one. Any other questions before I go to the next slide? So there are mental health terms that I'm about to pull up on the screen, and I hope they pop up. Do you all see mental health terms? Don't see it, do you? Do y'all see something that says mental health terms? Okay. So we're going to go through these really fast, but you will get a copy of them. Addiction. These are terms that comes up. You need to know what an addiction is. An addiction is when somebody is dependent on a drug. When it comes to a test question, one of the test questions reflects around withdrawal from alcohol is one of the highest killers. Did you all know that people die from alcohol withdrawal more so than they die from any other addiction? With adjustment disorder, you have to know, if you ever been one of my students, I tell you keywords that you need to look for are time frames, the sex, gender, things of that nature. So, yes, Master.
And see, all I see is like a list, but I don't see anything. Like you didn't click on anything.
Okay. Sorry. Here we go again. Thank you. I have never had this much problem with Zoom, but it's normal. Okay. It's normally Pearl that gives me a headache. All right. So with adjustment disorder, remember, it lasts less than 6 months. It's acute, it just comes on. Affect is how that person is sitting there, their emotional state. This is one of those things that you're looking at subjectively, and this is what you're doing during your assessment. This is part of the MSE we talked about earlier. Let's see, agoraphobia. It shows up on the exam a lot. This is a fear of public places, and it can look like anxiety as well as a panic attack. So just be mindful of that one. Amnesia, you have to be able to differentiate on the exam. Like if somebody came in and they had a fall or they was in an accident, and they may have amnesia, which is they have a partial or complete memory loss. So that's when you do that MSE by asking them, assessing them for date, time, and sometimes you have to get more than alert and orientation times 3. You have to dig deeper just to see what's going on. Also with amnesia, you have to be able to differentiate if it's dealing with a 65-year-old or 80-year-old on the exam who's having dementia, or is it amnesia. So this would differentiate mean. So you have to be able to know, and a lot of times with diagnosis, they have time frames, and that's how you can differentiate. So far, any questions, comments, or concerns? Anorexia, we just talked about that. A lot of times, again, on the test, it's going to show up in women. I do want to say that in real life, the men are starting to become more prevalent than women. And Cassandra, I'm going to pick on you for a second. I want you to read this one.
Okay. The anorexia.
Uh-huh.
Anorexia nervosa. I don't know. I think I said
You
that.
said it right.
Okay. Anorexia nervosa is an eating disorder characterized by excess control. It's a morbid fear of obesity that leads the sufferer to try and limit or reduce their weight by excessively dieting, exercising, vomiting, purging, and using diuretics. Sufferers are typically more than 15% below the average weight for their height, sex, and age. Typically, they have amephoria. What is it?
You said it right.
Okay. Female or low libido male. 1 to 2% of female teenagers are anorexic.
So you see, when we talked about the question earlier, these are things that you have to be familiar with. So it'll start standing out on the exam like, is it this or is it that? Anybody have any questions about this? The way anxiety is going to show up is it's provoked by fear. This could be like, I have anxiety. Oh, I get anxiety if somebody come to me and give me a job application and ask, y'all may think I'm joking, but if I ever have to go back in somebody's office, y'all probably just be coming to my funeral. And I mean, I start sweating. I get offended, and I be like, "Why you giving me an application?" They be like, "Girl, I think you need to go back in the office." No. Because when my last three jobs in my career, I was having panic attacks. When I stopped working, the panic attack stopped. And a panic attack, I thought I was having a heart attack, y'all. So that ain't the only thing, but I also reptiles. If you could put a rubber snake on my floor and my anxiety just would increase. And then the worst of it all is, are y'all familiar with shag rugs? Man, put me around a shag rug. I might pass out. Like I would tiptoe if they on display in the store. I have to tiptoe around it crazy. But I say things to make y'all remember, but those are true stories. So anxiety makes you feel like there's somatic symptoms, which somatic symptoms look like you're having a heart attack, look like you're having a stroke. So you have to understand the difference between somatic symptoms and real medical issues. Question, comments, or concerns behind that? I just think I made my anxiety go up talking about them three items. Um, let's see what else. Uh, compulsion, confabulation, cyclomania. Anybody seen this on the test? Anybody want to read it?
What's that? The cyclothymia?
Mm-hmm.
Variability of mood over days or weeks, cycling from positive to negative mood states. The variability is not as severe in amplitude or duration as to be classified as a major affective disorder.
So this is an important term to remember because again, it talks about time frame, mood over days or weeks, and they cycle. So this looks like bipolar. It looks like schizophrenia. So you really have to remember that word because it's dealing with time. Deja vu, it doesn't show up on the test like it used to, but just remember, it looks like a disassociation almost. It can also make a person feel like, wait a minute, I just saw that. It can also look like magical thinking because a person can be like, I know this just happened. And they're really trying to convince you that they've already seen it happen or whatever. Questions, comments, or concerns about those? Delirium. Does anybody have problems with delirium?
Is delirium like an onset?
You have, oh, just 1 second. Miss Hunter, why you have problems with delirium?
Because I practice on pocket prep, and it's always delirium, delusion, or dementia, and I confuse delirium and dementia. Don't ask me why. It's just it might be because I'm trying to remember the answers to these questions, but those are the three:
Ain't nothing
delusion,
like.
delirium, and dementia.
Go ahead and read delirium.
An acute organic brain syndrome secondary to physical causes in which consciousness is affected and disorientation results, often associated with illusions, visual hallucinations, and persecutory ideation.
Now read delusional.
An incorrect belief which is out of keeping with the person's cultural context, intelligence, and social background, which is held with unshakable conviction.
Okay. So here's the thing. These both can look like medical. And so with that being said, a person can be in pain and start feeling like they're delusional. And with delirium is also one of those things. It's caused by the physical stuff. And so what it does is delusional make you see things. Delirium makes you let me make sure. No, delirium makes you see things. Where have you ever been in a lot of pain?
Yeah.
You be in the pain so bad, you be like, "Ooh, I'm." I'm seeing stuff or I'm hearing stuff. Have you ever been in that type of pain?
Only when I was in labor. I ain't never been in no like horrible pain or nothing like that.
Okay, just 1 second. Somebody just raised their hand.
I did.
Okay.
I'm in an IPP ward, and so we get this a lot with our jury population when they
Mm-hmm.
commonly have UTIs.
Mm-hmm.
And it's always an issue because there's never really a medical rule out. They always want to just put them in IPP, either
Mm-hmm.
because they have a pre-existing mental health disorder. But if you're like 73 years old and you don't have any like mental health history, it's more likely that this could be something that's organic, which is like a UTI.
Mm-hmm.
Sometimes it'll be like they're talking, they're interacting with stimuli, um, but it's really just delirium based on it. It could give off what maybe might be some type of a psychosis. Um, but like they're really like firm in their convictions, like they really think that they are speaking to somebody in their room. There could be bouts of like there was somebody who did like break a leg and went into shock and was constantly like talking to the extent of they had like a fracture that actually had to be repaired. But this is like one of the things that we see a lot. And sometimes obviously we see dementia in our jury population too.
And it is one, like I said, it comes along. Thank you for sharing it. It comes along with medical. And the UTI is a prime example. That's when a lot of people show up as delirium. But I had surgery on my shoulder last year. And for 11 months, I would be asleep and I would just wake up out of my sleep with pain. And my kids would say, Mama, we thought you was really in your room having a conversation with somebody. The pain is that bad. And so that's what it looks like. That's why I said it's secondary to physical causes because it's something that has happened to the body that creates a lot of pain. Has any of you ever heard of phantom pain? Anybody familiar with phantom pain?
Yes.
So a lot of
I
Heard of
am.
it.
you are have you must have had
Yeah.
an amputation.
I did not, but I did social work in the nursing home and I did hospice for 30 years. So I
Mhm.
dealt with people. It's kind of like even if they amputate your leg, it still hurts.
It still hurts. So
Yes.
people have dealt with this pain for years, and then they cut the leg off, and for 6 months later, the person is still sensing that pain, and the you like your leg is gone, and they said the pain is actually 20 times worse than what it was when the leg was on. But those people, pain is so bad where they start seeing and hearing things, and like it was mentioned earlier, they're having conversations. And so with the delusional piece, it's just you're delusional, and both of these are temporary. I want to make sure you remember that too. But delusional is like somebody saying, "Oh, do you see that alien standing right there?" And so delusional is going to show more like in a psychotic but it can show in a medical, but it's going to be more in a psychotic area. So remember, delusional is psychotic. It's something that's really not there. If a person is trying to tell you it's a pink elephant in a room, and you know it's not a pink elephant in a room, it's a delusional. Delirium is going to be related to pain. Make sense?
Yeah, is
Yes.
delirium like delirious? Because you
Yes.
said that. Okay, so that's a way to
Mm-hmm.
remember it. Like
Mm-hmm.
he or she is delirious.
Mm-hmm. But on the test, it's going to say delirium.
Yeah,
In
I
in
know.
the real world, we'll say delirious. And then there go that dementia, which is very important to remember because as it was mentioned earlier, the person with dementia can also look like they having a mental health illness. And so the only way you're going to get a true diagnosis of dementia is by using a tool to assess the person. Depression, you all should know that one. Ecolia. Anyone seen this on the test?
Echolalia?
You see, that's what I have. Right there. I just gave you a prime example of it.
I have seen it on the test first as well when
Now,
we're
Miss Honey,
discussing,
you gotta remember that one, aren't you?
uh, especially when they're talking about kids on the spectrum.
Yes. And I'm probably on the spectrum. But with that being said, so y'all gonna be like, this girl done had, if anything can happen, it can happen to me. I had my wisdom teeth pulled. And I woke up and about for 6 weeks, I was like, well, I can't feel the right side of my face. So the feeling finally came back, but the feeling never came back in my tongue. So I actually have a speech disorder because half of my tongue doesn't work. So with that being said, but this in a sense, it is a speech disorder, and it's like people they repeat the last words or the last thing somebody says. So a person can be like, "Girl, I went to the mall and I brought a brand new pair of shoes," and they can be like, "You bought a brand new pair of shoes," and they can be inappropriate. And like it was mentioned, this is one of the primary diagnoses with individuals with autism because people with autism can appear as inappropriate. Hallucinate. See there? It gets bad at nighttime, but hallucination. Remember, this is one where it's a sensory thing, the external space, the absence of what is really going on. So the abnormal sensories are not working. Mania. Does everybody understand mania?
Yes. Well, I do.
Okay. You want to tell us?
So mania, I mean, everybody uses this word a lot, but until you like live and breathe and with the same space as people, you really don't know what it looks like. People will be up for all hours of the night. They'll like clean their room. There would be periods of like grandiosity where they think that they're like composers. I see this a lot in the psych ward, and usually it could go on for days. Sometimes it's actually for some patients, unfortunately, a week until we can get some like meds in them.
Yep. And that's what it is. So anytime you see the word mania, think about Tasmania Devil. I probably just told my age again. Y'all remember him? So that's what you need to think about because mania shows up in like schizophrenia. And so you got to be able to differentiate. And just remember, it's somebody that's going. I have a client now. She got a daughter with autism. She said, Miss Bogart, she ain't slept in 2 weeks. I'm like, ain't no way. I don't know. But you never know a situation until you in it. But that's what mania looks like. So, uh, seasonal affective disorder. This is happening a lot. So I want you all to remember with seasonal affective disorder on the exam, it may be assessing you to see if you understand that people only get depressed during the winter months. And in that, it's real depression, but it only happens when everything gets gloom, like people are snowed in or it's really cold. And so one of the things that they have to consume is either medication or you can ask them to start with the small thing, which is a light box. Has anybody not heard of seasonal affective disorder? Okay. Y'all probably hear Dr. Pam talk about it all the time. Tartar dyskinesia, you need to know that one. Let me show you. So tartar dyskinesia
What was phototherapy? What I seen that on there.
on the test.
On the seasonal affective disorder. It says antidepressants and phototherapy.
That's a light box. Anything that's going to give you a feeling of warmth.
Okay.
But you take that person, they may have, so just say if a person lives up north and they end up with seasonal affective disorder, they do things like purchase light boxes or even they buy property in like Florida and fly out to Florida until the winter months are over.
Okay.
Yep.
I
So
thought you
anything
took
that
this out of the DSM.
Oh,
huh?
I thought that the SAD was taken out of the DSM.
Seasonal affective is still
Still in there?
Mm-hmm.
a lot of
If
people in
I'm wrong, I'm wrong, but I want to say it's still in there.
Alaska, a lot of people have this
Yeah.
because
That's
of the dark.
mm-hmm. And it's happening more in the United States. That's why, again, I said, like the people who live up north, when it gets really, really cold, they purchase property like in Florida in the South and go south. Now, you can check it. If it's not in there, Hey, I don't know everything, but I want to say it's still in there.
And
So,
you mentioned about the cold, but I have a patient right now, and her son, when I did a visit with her, he kind of telehealth in, but he's in Puerto Rico, and he says he can't take the summers there, that it's
what?
too hot. And so he comes home and has stays in an RV because he says it's too hot.
Wow. So I don't, that's a new one. Somebody want to write a paper, somebody trying to get a doctoral degree, there you go. I can see it happening though. I can start seeing it happening. Yep. So tardive dyskinesia, we have to know this one. I strongly encourage anybody to Google a picture or Google the word tardive dyskinesia and look at a photo of it, because what it ends up, it's a involuntary movement disorder, and what it does is it starts messing with the limbs, and a lot of times just the whole body. It affects the body, and so just make sure. I don't think it still shows up on the exam.
Um, in medication, I think they do, because it's usually for people that have been on psychotropic medication for periods of time. So I actually also see this as well, and I didn't know what it was until I saw it. And the jerking movements can sometimes appear very odd. So, well, for instance, I was doing a group on an inpatient unit, and there was a patient that was doing what was called tongue darting, and it almost looked like he was sucking his teeth at me while he was in my group, and I was like about to crash out. But it really was
Wow.
because of the tardive dyskinesia. And then, when they also try to combat this with offering the patient cogentin, which has also shown
Reverse.
up in the exam when I ever do some of the medication questions, but it might not be like on the ASW type of exam questions. These are usually the questions where I see this
ALC.
when someone is, when like, or even when it's like Suisa's writing the test, like, or when other people are writing their own test questions,
Mm-hmm.
that I see these type of questions. I don't see them on the ASWB
Yeah.
type test.
That's what I was thinking. It wasn't there, but it is good to know because it does really happen to people in real life. And it could be confused with tick, so you have to be mindful because the limbs start doing things. Like I said, it affects the face, the tongue can get real big in a person's mouth. But the most you need to know about it is that it's reversible and it's induced by medication. A lot of times the individuals with tardive dyskinesia, they're taking strong medication, so they probably have a diagnosis of either schizophrenia or bipolar. So, any questions, comments, concerns about that before we go on to the next thing? Are you all learning anything? Okay. So, let's go here. Stop sharing. Jess, where do you work at again?
I work at an inpatient unit in Staten Island, New York.
Okay.
So it's a lock psych ward. So we don't have a
Mhm.
CPAP. So these are people that are being admitted. Usually they have a 72-hour hold. So sometimes we are getting people that do not medicate, and then their length of stay also is a thing, because I'm often sending them to state for inability to access the next level of care, or
Okay.
doing what we call AOT orders, which are assertive community action orders. So like Kendra's law.
Okay. Just remember, when you take the exam, do not take the exam the way you work.
I get this a lot. And so sometimes I'm told either, for lack of a better word, answer the question like an old white lady,
Mhm.
or pick the most social worky, nicest response ever, because
Mhm.
you're never really, this is not what you're really doing in practice. But
Yep.
as Dr. Pam says, that this examination is given to all social workers within the states. And so the same person that's answering this question in New York will be answering this question in Arkansas.
Yep. That's why I said do not. I could tell because I did that. And so I just want you to know, don't do it. All right. Do y'all see where it says autism spectrum disorder? No, y'all don't see it, do you? Jesus! If I drink, I sure would be drinking tonight, but I don't drink. Okay, here we go. Please tell me you see it now. Y'all see it now? Okay. So autism spectrum disorder, y'all. Woo! Okay, first of all, this is it just seems like every baby that was born out the COVID is being diagnosed with this. But that's not going to show up on the exam. However, what you need to know about this, because it does show up on the exam, it will always be a child. They're typically they are going to either be born with it. It can also look like Asperger's disorder on the exam. And what it's going to do is talk about in the vignette, the child is having poor communication skills, they have repetitive behaviors. There's a deficit of attention. So you have to know this so you don't get it confused with ADHD. Sometimes uh the repetitive disorder or the speech language repetitive disorder, they don't sleep, and again, a lot of times it's caught between the ages of 3 and 5, but statistics are showing, not for the sake of the test but in real life, that kids are not being diagnosed even after the age of 5. So any questions about autism spectrum disorder? Because with this chapter, that's basically what we're doing, is just giving you information. Did that happen? I apologize. I hit the wrong thing. Has anyone worked with kids with autism?
I have.
We need a lot of more social workers. A lot of social workers don't like working with kids with autism because a lot of their problems look like behavior. So this is the next thing I do want to talk to you all about in this chapter. I had to bring the screen down. The stages of behavior change. Are you all familiar with pre-contemplation, contemplation, preparation, action, and maintenance? Because a lot of people get this confused. Anybody get it confused?
Does this relate to stages of change when you're like an addiction, or is it the same type of format?
This is the stages of change when you're coming into therapy. What? So that the pre-contemplation is when you know what, it is using addiction as well. It has that person, but it's therapy in general. But that person does not recognize they have a problem. Everybody is telling me that I'm having a problem. Oh, Sherry, you gaining a lot of weight. And I'm like over here, like, I don't know who they talking about. And then it gets to the point where I come to the contemplation stage where I'm like, okay, I can't wear any of my clothes. I just had to go spend $400 at the Goodwill on all these clothes, whatever, whatever. So that's the contemplation. Something has happened that's truly letting me see that there's something that needs to change in my life. So the preparation and the contemplation stage, they overlap one another, because in the preparation, that's when I say, you know what? I am going to go see a counselor. I'm going to go see a dietitian, and I'm going to go see a fitness coach. So that's why I'm taking the action. And this is pretty much like some people with the exam. A lot of times people say, you know what, I don't need your friends like, girl, you done took that test 13 times. I'm talking about me. I'm 12 times and you still trying to take it. I'm like, ain't nothing wrong with me. This test rigged, because that's how we all think. And then I come to the point, I'm like, look, shoot, I see something needs to happen. So then the preparation for me is I come to Dr. Pam. And then after I do the preparation, I'm doing all the things in the action stage that Dr. Pam is telling me to do so I can build on my skills. Then I pass the exam, and then I maintain it by teaching other people. So you think y'all remember the stages of the behavior change? Because it shows up on the test and it's showing up like the person already came to session. What is the next thing for them to do? And it could be action. It may appear that you're going to do an intervention. So those words intertwine with each other. Questions, comments, or concerns? So this gives you the definition of everything right there. So the next thing we're going to go over is ego strengths. This shows up on a lot of vignettes. Are you all struggling with the definition of ego strength? Anybody? Uh-oh, somebody put something in the chat for me. Okay. Anyone struggle? Okay. So remember with ego strength, somebody struggling?
I do a little bit. Sometimes I do good, but other times I get confused on it.
Okay. So in essence, the definition here is you got to remember your id, ego, and superego. What does your id want? Was that Cassandra that was talking?
Yes, ma'am.
So do you know what the id wants?
I think the id is kind of just want whatever. Like, the id wants whatever it wants. It's just
It wants whatever it wants. I want it and I want it right now.
Yeah. Mm-hmm.
So I'm going through these for a reason. What does your ego want?
The ego, it's like, okay, I know the id, the super ego is like the battle between the both, right? Or like trying to,
That's the other one. That's
see what I'm saying? I be getting
mhm.
the ego is the ability to then to have that self-control and different things like that, right? To reason or
Your ego reason. There you go.
yeah,
You got the
yeah,
devil on the right shoulder and the
right.
angel on the left shoulder. So
Yeah.
what's your super ego?
I felt like I knew this, but I probably do. I'm probably just freezing in a moment. Um, I thought your super ego was so your ego is the voice of reason.
And your super ego is your morals, the
Okay.
things that you've been taught. So I
Yeah.
went through those because with your ego strength, the ego strength is basically it's just like how can I being able to um pick out reality. And so
Mhm.
what you in the midst of things, you don't have to go through, am I gonna do the good or the bad? You're actually using your super ego in a sense to build on your strengths. So it's just your ability to be able to face things and look at it in reality. Did that make sense to you?
Yes.
Yeah. So you don't have to have a defense when something goes on or something. You don't have to put up defense about it because you're living in the real thing. You're practicing those morals, which coincides with your super ego. Let's see what else for the sake of time. So these are things that do anybody remember the axis 1, 2, and 3? And the gaff. So although although the gap has been taken out of the DSM-5, this is something that you most definitely need to know. In the real world, some companies that you work with, sometimes the insurance companies wants a gap, especially if you're completing paperwork for people who are seeking family medical leave. But the other thing that you have to know is The new thing that's been added to the DSM-5 is the WHO, which is the World Health Organization Disability Assessment, and it does replace the GAF. And in essence, what you're doing is taking on what's going in an individual's life as a whole, and you're characterizing it, and it's typically used for insurance purposes. So if you see the WHO pop up, that's what it's about. Now, neurodevelopment disorders, remember, we don't say somebody is mentally retarded anymore. We use the word ID or intellectual disabilities. Did you all know that? You get sued for saying mentally retarded. So just be mindful. Um, and so this is where the IQ comes in, because a person IQ would determine what status, where they are with ID. And this is often how people end up getting not child support checks, disability checks. So do keep in mind with neurodevelopment, because that's dealing with the brain, the things that come along with it are like communication disorders. So you have language barriers, speech barriers, something again that can look like autism. But the reality is, you got to make sure the question is saying that it's something that has changed in the brain, or it was something that was identified as a brain, a cognitive distortion when someone was a child, because this is an onset of childhood. A lot of times kids are born with neuro issues. Questions, comments, or concerns? Do you feel like you'll be able to differentiate that between autism? Nobody's talking. Okay. So let's go to the next one. These are stereotypic movement disorders. And so you want to make sure when you're assessing kids, like, or you're really asking a parent, there comes a lot of collateral when you're working with kids. And so you got to assess to see if they're picking their skin, if they're nail biting, pulling their hair, things of that nature, because those are items that resembles the tic disorder. It's also a lot of rapid movement. Sometimes it can just them be blinking their eyes a lot. They can be jerking. I actually have a cousin that's diagnosed with tic, and it's when he it's funny because we're like third cousins, but when he goes to work, y'all, that's when his tics start acting up. So he's like, I don't think I'm gonna be able to work. But just keep that in mind. They shrug their shoulders a lot, and even sometimes when they're trying to say certain things, it bothers them. Jess, is that you? Because it's not saying your name, it's saying you as somebody else. Is that you with your hand up, Jess?
It's Nicole.
Okay, Nicole.
On that one, it had the hand shaking.
Mm-hmm.
Like they were, but I don't understand what are they trying to figure out by shaking the child's hand?
The child would just kind of take your hand and be shaking it like that.
Oh, all right.
Mm-hmm. Mm-hmm. Tourette's disorder. Remember, that's neuro as well. And so you got to be able to understand with Tourette's, what you're going to see, it also resembles tic as well. And so it's an abrupt movement, but the difference is with Tourette's, it's going to show up in adults. And then you're going to have tics that shows up in children more so on the exam. Questions, comments, or concerns about the two? You have your schizophrenia and other psychotic disorders. And under this, we have to remember schizotypical and schizoid are personality disorders. So please do not get those confused. Are you all familiar with schizotypical personality disorder? So these are individuals, they don't like to be in social settings, and they often look odd to other people. So when they do come out, you may see them like in a grocery store and they looking straight forward, pushing the cart. You like, oh, they look a little odd. They just really stand out. Um, You probably would end up saying, man, that's somebody that probably end up killing somebody. Of course, we have to be mindful that we're judging people, but that's how schizotypical personality, individuals, schizotypical personality disorder look. So also in this category, which is new, but Cassandra, this may be why you like, oh, I'm having problems with this delusional stuff over here. There is a delusional disorder as well as delusional. But keep in mind, it's the same thing. It's false things. It's something that's not real. And Cassandra, I just want you to read right here. Delusional is not always related. What does it say?
It's not always related to underlying conditions. It might be caused by stress, alcohol and drug abuse, and certain medications.
So just like I was telling you all earlier, delusional normally comes on when it's a medical condition, but it can also be caused, because I don't want you to be like looking at a test question like Miss Sherry said it was only medical. It was something physical that happened to a person, because it can also be caused by stress, alcohol, drug abuse, and certain medications. You need to also be aware of brief psychotic disorders. With brief psychotic disorder, it's just what it says. It's brief. And during that brief moment, the person is, again, they're having delusionals, hallucinations, disorganized speech, or they can be catatonic. Everybody knows what catatonic is? Do you not know?
So I just have a question because I've seen this before, but I wasn't sure. Is it when someone kind of like blankly stares, does it really interact with like the outside world or stimulus?
They're just stand still. Have you seen on television or anywhere? This is not it, but to give you an example, like people they're using drugs and they just kind of bend over and
Mm-hmm.
they're just stuck in their position.
Yes.
That's what catatonic looks like. And a person can be stuck in their position. So I work in a mental, I do what I'm called a CON, a commitment of need writer. And so at nighttime, I get called by the psych ward and I assess people. And I had a catatonic person. I was like, I can't assess that person. And I mean, I really did assess them. I was like, how long they been like that? They was like, they brought them in at 8 o'clock, Miss Bogart. It's midnight. And that person still just standing up on the wall. They have not moved. They're still breathing, but they catatonic. There's no speech, no movement, but they still breathing. And then they'll just come out of it like somebody just dashed water on them. They just come back like nothing was going on. So it's a standstill. You do need to know schizophrenia form, but I'm not going to go into that because the one you truly need to know is schizophrenia. And so with schizophrenia, you have to remember a person can have positives or they can have a negative. So think about a battery when you're thinking about schizophrenia. And so you also have to remember the time frame. A person must experience disturbance, psychotic, which is disturbance means psychotic symptoms for at least 6 months and have at least 1 month of active symptoms. So it has to be at least 6 months. And so what ends up happening with the positives, that's when a person is presented with delusionals. You can see this. They're talking to people. They hear things, they see things with the hallucination. They're talking to somebody and it's not you, or they're not using complete sentences, or it just doesn't make sense what they're saying. And then those negatives is the flatten effect, like they're saying it's this look that does not match anything else, reduced speech. They can't even answer simple yes or no questions, and they're not attentive at all. And so that's what you have to remember, the time frame and that there are positives and negatives. Anybody have any questions, comments, or concerns? Okay. And then let's see. Schizoaffective. I don't think it's showing up on the test that much, so I'll skip over that one. Has anybody seen a schizoaffective on their test?
I have. I
Oh,
feel
you
like,
are.
you know.
You're seeing it.
Uh-huh.
Okay.
As an answer choice.
That's what I was thinking.
Yeah,
Okay. So would they want to make sure normally the answer would be schizophrenia, but because all of these one causes the other, or after one, then it's the other, what you want to remember with schizoaffective is that there are symptoms of schizophrenia because it's trying to see if you could differentiate on the exam. And what's going to be is still those hallucinations, delusional, the manic, like we talked about earlier. That's why I gave y'all the definition. And also, what you have to remember with schizoaffective, just like schizophrenia, they are saying that it's genetic. It can also be with schizoaffective, but it can also be drug induced. So keep that in mind. And let's see. Um, it's not showing up that much. I'm trying to make sure I highlight the things that you all need to know. So here's catatonia. Jess, you was talking about it earlier. You want to read it?
Catatonia requires 3 of 12 symptoms. Catatonia may be a specifier for depressive, bipolar, and psychotic disorders, part of another medical condition, or another specified diagnosis. Definition: a neuropsychiatric disorder which affects behavioral and motor functions. A. Catatonia associated with another mental disorder. A. This is a catatonia specifier. B. Catatonia disorder due to another medical condition. C. Unspecified catatonia. D. Other specified schizophrenia, form, spectrum, and other psychotic disorders. E. Unspecified schizophrenia, spectrum, and other psychotic disorder.
Did that make sense to you?
I have never heard of it as a specifier, but sometimes people just say, oh, well, this patient is catatonic. And then they'll just probably like load them up with like, I don't know, Ativan to like break up the spell. But there have been points where people don't eat and then we have to like insert a feeding tube. Like they won't even function at all.
Yeah, because they can't. You put something in their mouth, you pour some water down their throat, you're gonna choke them and they can't respond to that. So you have to be real careful. So you guys remember that catatonia, those specifiers, right there, and you will have this to look at later. But you need to know what catatonia is. Because a lot of people are coming into hospitals and stuff now. Like I said, it's drug induced and it looks like it, but you got to be able to tell. Who wants to talk about? Let's see. Actually, Hillary, tell us about bipolar.
Well, bipolar is a mood disorder,
Mm-hmm.
and which when we talk about both of them, bipolar one, distinguish between the two. It's got to do with the changes of the highs and the lows. And with bipolar one, it comes with the mania, and bipolar two comes with hypomania.
Yep.
That's it. Okay. And duration for one is 4 days more, so about a week. And bipolar two is going to be less than 4 days, 4 days and less.
There you go. This will show up on your exam, and you do need to know depression versus manic depression. And so, just like it says on here with depression, you have a person that they just lower everything a lot of times that they do. They don't want to do anything anymore. And then you have that manic depression, which is experiencing those high episodes. And the person is just like, you're like, what's going on with them? But a lot of times they will come down. Also, both of those together with depression and manic depression, the combination of it is going to be the person will be irritated. There's going to be aggression. There are suicidal thoughts. That's why you're always assessing for safety when you're dealing with somebody dealing with either schizophrenia or bipolar. You assess as best as you can. And then there's changes in sensations like the way they sleep, the appetites, and things of that nature. And so this shows you all the time frames you will have this information. Just like Hillary touched on, With the manic episode, the duration is 1 week. With the hypomanic, the duration is 4 days. So Hillary, you got an A on your test. So keep those time frames in mind because it's very important. Bipolar does show up on the exam a lot. What you need to know about bipolar is that they are still giving out the medication lithium for that. And it does show up on the exam, but they want to assess you to see if you know that with lithium, a person has to have their blood work checked. Hillary, I'm going to get you.
Would we see Depakote?
Huh?
Would we see Depakote as a variant?
It's not showing up as much on the exam anymore. And the only reason they're asking you about lithium, because a lot of people think lithium is not being used anymore, but it is being used. And so that's how it shows up basically for the for the sake of bipolar, because it's one of the strongest and best medications for bipolar.
I did see a question where it talked about contraindication because prolonged use does, I think, kidney damage.
Yes, but it's the best it's still the best medication, and that's why they have to do blood work.
Yeah.
Yep, it's the best medication, unfortunately. Especially when you have someone that's all over the place, they have to, something has to be given to them to keep them chemically balanced. Now, it's not showing up on the exam, but in real life, for schizophrenia, they're becoming more prevalent. We're giving out injections because a person with schizophrenia a lot of times does not have the capability of taking a medicine consistently. And so if somebody, their overseer, like a durable power of attorney or someone can bring them into their medical appointments every month or every other month, then they give them the injection and it lasts longer. Any other questions, comments, or concerns? Let's see. So bipolar 1, manic, bipolar 2, hypomania, and psychothymic is going to be hypomania, but it's mild. And remember, anything with psycho, normally it's going to be 1 or 2 years because that's the duration is longer. And so keep that in mind. Bipolar 1, the duration is about 1 week. Questions, comments, or concerns so far? On the test, you will see that cyclomania shows up in children as well as adults. Again, the 1-year time frame is going to apply to children, and the 2-year time frame is going to apply to kids. Also, what you need to know is it's called dysregulated. I'm drawing a blank. Mood disorder. That is the cousin to bipolar, and that's the diagnosis that is given to a kid.
Mood dysregulation disorder?
Mood dysregulation. There you go. Thank you. Did everybody catch that? Okay. Let's see. Disrupted mood dysregulation disorder. So again, this is the cousin to bipolar. And what you need to know is it's like a child on the exam. It's going to talk about a kid having a temper tantrum, but it's not a normal temper tantrum. It's like a forever temper tantrum that never stops. The kid stays irritated all the time, frustrated, and it happens in any type of setting. Whereas a temper tantrum may show up as a child that's under the age of 3 on the exam, and a temper tantrum can be stopped. So any questions, comments, or concerns behind that? You would see it as DMDD, which again is a child with like extreme rage. Have you all seen that one on the exam?
On the ally side, when they were trying to talk about the new kid disorders, because I think this one's fairly new.
Okay. Yep. It's so please be mindful. It's one what it's testing you for to see if you can differentiate between a child with a diagnosis that resembles bipolar versus an adult. So make sure you're looking for the keywords, the length, whether it's if it's saying it's a 8-year-old versus a 28-year-old. And one thing I want to go back with schizophrenia is that a lot of times people aren't diagnosed with schizophrenia until after high school, typically around the age of 19 or 20 or higher. Anybody familiar with PMS disorder? Okay. So
Yeah,
this
that's
is
the
short.
premenstrual
Uh-huh. Oh, you can go.
disorder. No, I'm
You want to
sorry.
tell us about it? I can't see you all for some reason, so I apologize. Go ahead and tell us about it.
It's the premenstrual disorder is where basically you're having a lot of pain um and depression and mood symptoms, um not just during your cycle, because it's like what 2 weeks before it
Mhm.
starts, and basically it's the whole month from basically the way it works, kind of
Mhm.
like 2 weeks before and weeks afterwards. You're having discomfort.
Yes. Yeah, I was diagnosed with this until I had a partial hysterectomy, and my family loves me now because I was being fired by everybody. It is the worst. People was just I stayed moody all the time, but I had to learn how to manage my mood, and so I end up displacing my feelings on my family, like when my work day was over. But it was hard. Um, People with PMS syndrome, they're often anemic. Of course, it's in females only. And then they start presenting with symptomatic disorders, some somatic disorders like a migraine, the cramps, a lot of pain. You can't sleep. You want to eat chocolate a lot. So just be mindful. This is going to show up as a female on the exam. And it's trying to see if you can rule out if it's medical or if it's PMS.
It's also PMDD, so
Mhm.
they like kind of coincide with one another. So, um, is there a distinct difference between what we should be looking for between PMS and PMDD?
Mm-mm. They're basically the same because those symptoms occur 2 weeks, 1 to 2 weeks before. And
Mm,
remember, the time frame varies on what you're looking at. It could be 1 to 2 weeks before and 1 to 2 weeks after the menses.
okay.
Yeah. What you need to know about anxiety disorder is well, let me first start with separation disorder. Separation disorder is typically going to show up in the exam as children who are having a problem with being separated from their parents. But believe it or not, it's an attachment piece that's a big part of this. So you have a lot of adults who actually presents with separation anxiety also. You have wives that presents with separation anxiety from their spouses or their husband. But for the sake of the test, it's going to typically be a child that's age 4 or above, and it can go on for years. Like this is when you drop the child off at school, you'll see test questions. The mama dropped the child off at school every day, and the child just crying, and they're in fourth grade. And the teacher like, why is this kid crying like this? And then the whole time that they're at school, they're like, I need to call my mama. Will you call my mama? So the teacher literally has to call the parent for the child to hear the parent's voice and for the parent to say, I'm okay, Susie, and I'm gonna pick you up at 2:15 at dismissal. But this goes on for years and months. But that's how it's gonna show up. Selective mutism also shows up on the exam. We thought this was my grandson. But with that being said, this is when you have, again, it's going to show up in kids on the exam more so than anything. And it's because they're outside of their their home. And so what they do is, or they can be in an environment where they don't feel comfortable, and a person can be like, do this child talk? And the parents be like, they talk their butt off at home. But when they go out in certain areas, it could be various areas, they just stop talking. They really cannot talk at all. And people think it's a facade, but it's something that triggers, and the brain just makes them shut down. So remember that does coincide with social anxiety. So if a kid, or if it's going to show up as a kid, and often they're outside of their comfort zone. On the exam, it's going to more so look like they're outside of their home. Questions, comments, or concerns? So we're coming to an end. Let me see what else. Panic disorder, I touched on this earlier. For the sake of the exam, it may look like a heart attack, it may look like a stroke. A client can be in session on the exam, and it could be something that came up in the session that triggered them. So now they're responding to it. But you're going to always rule out medical first to identify before you figure out if it's a panic disorder, or the other word used interchangeably is panic attack. Questions, comments? Oh, and the other thing that you need to know about panic disorder or panic attack is on the exam is, once a person has a panic attack, they are anticipating when they're going to have another one, because it's so uncomfortable that now they're living in fear of, when am I going to have my next panic attack? So that's something that you're going to see on the exam. Questions, comments, or concerns? Let's see what else you're going to have. Generalized anxiety disorder. This just means that every day, all day, the key word is a person is worried all the time, and they cannot control that. So those are what you're looking for. A lot of times it's going to show up in a female. It's going to be a female on the exam. Again, it can look like a panic disorder, but there's a lot of compulsiveness that's tied in. It's a lot of anxiety because they're worried about everything. And so this is long term. A lot of times it's not reversible. It takes a lot of trauma trained individuals to work with these clients, as well as they have to learn coping skills, which for the most part are going to be like grounding techniques. Questions, comments, or concerns about that? Okay. So teaching this is boring, y'all. I would say that. You would need to know the difference between OCD as well as OCD personality personality disorder. And so remember, OCD is a person life is just disrupted. So this is the person who they're late for work every day because they drive 6 miles and then they turn around and got to come back and make sure the door is locked. They turn the stove off. So they're always checking things. And so what you want to know, what you want to remember is OCD, obsessive compulsive disorder, disrupts a person's life. It causes them to get a divorce. It causes them to lose their job. And again, it's because they have this obsession with something, that something is not done correctly. Whereas with OCD personality disorder, a person is just seeking perfection. Questions, comments, or concerns about those two? Let's see. Hoarding shows up on the exam a lot. Anybody had a hoarding question? Wow, nobody had one. Well, it shows up. And in hoarding, you're going to also see a little bit of OCD. What you need to know is hoarding is caused by trauma. A lot of times it's childhood trauma. And so the trauma is replaced with something, and a person just keeps stacking. They start getting stuff. They kind of become obsessive with it. Like they'll go buy clothes from the Goodwill every Friday. And then before you know it, they just have all these clothes packed, stacked up in like all the rooms of their house, and they can't get around it. So again, hoarding is something that's dealing with trauma. And it's a way that a person just does not, they never deal with whatever the real problem is. And now they got a bigger problem. So these are typically what hoarders look like. I do home visits, and I have been in a house where this person actually just go to yard sales and collect stuff and bring it and put it in their house. And they just got a little path where you can just barely walk through. The only place you can get to is like from room to room, but they don't even have anywhere to sleep. They sleep in a chair all day. And then they got like dogs. They had like 5 dogs in the house. So the places do start looking like real congested, real disorganized. And with a hoarder, if you address this with them, they just like have a mental breakdown. On the exam, it's often going to be older people that have the diagnosis of hoarding. Mm, let's see. Remember, let's see. Enuresis. Anybody know what enuresis is?
Is that the holding of urine
Mm, try again. You
or
close.
Bone.
fecal matter?
Huh?
Fecal matter.
Uh-oh, say it again.
Is it the holding of like fecal matter?
Try it again.
Okay, because I had said urination, but you said no.
Oh, did you?
It's
Yeah, I said
urination, but
holding in.
it's not withholding it, it's going on yourself. Like
Yeah,
you using it on yourself. And then the eco or the other one is where you
pooping on
for
yourself.
number two on yourself, the fecal matter or whatever the case may be. So you have to push.
Encopresis is
Yeah.
pooping on yourself, and enuresis is where you urinate on yourself. And to get that diagnosis, an individual has to be 5 years. You may see 5, or you may see between 5 and 7. Because by the age of 5, between 5 and 7, we are supposed to be truly potty trained. This will also look like an Eric Erickson question, which would be autonomy versus shame and doubt. So just remember, enuresis is when, and and in real life, y'all, statistics kind of show that it's men that suffer from this more than women. And so there are a lot of grown men that are like married and everything, and they literally pee in the bed to this very day. I actually had a client, he had HIV, or have not had, he has HIV, and his girlfriend was just like, she started coming to sessions with him. She's like, I can't deal with this anymore. I can tolerate him having HIV, but I cannot tolerate him pissing in the bed every night. So it is real. There is medication that can be taken for that. And then there's secondary things like making sure, because it has nothing to do with drinking a lot of water and stuff, but that is a secondary thing. Just like stop drinking things at a certain time, try to empty your bladder before you go to bed, things like that. So, because we're coming to the end, any questions, comments, or concerns? No questions? There was one more thing I wanted to do. Um, so nobody have any questions? Okay. So Hillary and Miss Hunter, I think y'all were the last two to come on. And so I'm about to present you all with 2 test questions. Let me pull them up. Let's see. Let me make sure. I think that's the wrong set of questions. Hold up. Let me go back. Questions that I care about earlier. Okay, here they are. Do you all see questions on the screen? Nothing. Here we go again. Do y'all see the questions now?
No.
I don't.
Oh, Lord Jesus. Okay, thank you. Let me try again. Jess, you went to sleep on me over there?
Yeah.
Okay, Hillary, you'll be first, and then Miss Hunter, you will be second. It's saying it's showing now. Is it?
It is now.
Okay, perfect. All right, Hillary.
I can see. A social worker is, am I muted? No. Okay. A social worker is developing a treatment plan for a client facing eviction, parenting stress, and untreated anxiety. The client appears overwhelmed and says, I don't even know where to start, but it's the best treatment plan and strategy. So we got a patient who's in treatment and they're facing eviction, having parenting stress and untreated anxiety, and they don't know where to start because they're overwhelmed. So what is the best treatment plan and strategy? Focus on one area at a time and ignore others. Engage in collaborative problem solving to identify priorities and refer the client to inpatient treatment due to complexities. We'll definitely get rid of C.
Okay.
And we're going to go with B.
Why
Engage
B?
in collaborative. Well, for start, I'd like to focus on one at a time, but I don't like to ignore others.
Okay.
Ignore all the others because they kind of say the same thing, but they
Mm-hmm.
ignore others. Just kind of sound a little bit more unprofessional.
There you go. So you can go ahead and read that.
Engage in collaborative problem solving to identify priorities. Treatment plan should reflect clients' priorities. The treatment planning process involves problem solving. Given the client has several needs, the social worker and client should work together to determine priorities,
Okay, you can
focusing on
stop
one.
right there.
Okay.
So I want to say this real fast to you all. When a client comes in with several issues, you have to assist them with narrowing it down just with one thing. And a lot of times what ends up happening, that one thing that they say, this is what I prefer to work on first, the other things that actually kind of fall underneath that. So whatever intervention you put in place, it's kind of like killing three birds with one stone. So just keep that in mind. But any questions, comments, concerns behind that? Okay. Thank you, Hillary. Let's see. The next question is, oh, let me bring this down a little bit. Miss Hunter, are you able to see the screen?
Yes.
Uh-oh. Is it showing? No. Is it showing the whole thing to you?
Well, I can only see two of the answers, but I can see the whole question. Well, now I can see it all.
Okay.
A 27-year-old woman comes to therapy because of social problems. She reports ongoing difficulty maintaining friendships and romantic relationships because she simply cannot trust them. She believes that others have harmful intentions toward her, and she views even neutral events as somehow being evidence that others are threatening her or lying to her. What is the most likely diagnosis? Delusional disorder, schizoid personality disorder, and paranoid personality disorder. I'm going to rule out schizoid personality disorder. And I'm going to go with paranoid personality disorder
Okay. Why?
because everybody is out to get her and she doesn't have any proof that anybody is doing anything.
There you go. You can read. I want you to actually read all three of these. So read that whole thing.
Paranoid personality disorder are the symptoms described above that aligns best with paranoid personality disorder, which is diagnosed in people who have ongoing distrust of others. The person described shows key symptoms of of this disorder, including worrying that others are deceiving her, perceiving neutral events as being threatening. While schizoid personality disorder falls in the same cluster as paranoid personality disorder, it is not the best fit for the described person. Schizoid personality disorder involves detachment from others and lack of emotional expression rather than ongoing mistrust. Delusional disorder is diagnosed in people who maintain at least one delusion for a minimum of 1 month. These delusions might involve the belief that another person loves the individual or their one spouse is having an affair. For example, while individuals with paranoid personality disorder may accuse their partners of being unfaithful, paranoid personality disorder involves a larger pattern of mistrust not seen in delusional disorder. Since the person describes struggles with trust, paranoid personality disorder is the most likely diagnosis.
Yep. Did you hear that, Cassandra, about delusional disorder?
Yes.
So I hope with all the repetition tonight that you all got something out of this. And so as we come to a close, I'm just gonna go around. Jess, what did you get out of tonight's session?
So I was a little bit concerned about this part of the examination because I felt like at least like the L was a lot more community based and maybe the C is going to be a lot more clinically based. And I thought that I was going to have a lot of like more concerns, but it looks like looking at some of the common ones to kind of figure out the differences between them so that I'm able to like narrow the scope. Because there's no way you're going to be able to learn all the diagnoses, but maybe the common ones that come up, like I see a lot of schizophrenia, the differences between like bipolar 1 and bipolar 2, depression, some of the ones that you mentioned, and maybe just looking at time frame could also potentially help rule out.
Yep, that's it. Thank you, ma'am. Cassandra.
What I learned from today is that sometimes some of the symptoms and um, different things overlap with one another. So, you need to center in on looking at, keywords or, like you said, key time frames, the treatment options and different things like that. So that's kind of what I learned because a lot of different times schizophrenia can look something similar to like bipolar symptoms and different things like that. So understanding some of those key elements that separate them to, so you can know the difference in what your answer is.
And when you all look at this material that you get, it's broken down into sections like psychotic, neuro, things of that nature. So make sure you're paying attention to that as well. On the exam, you're going to always, I don't care what question it is, but you're going to always look at the gender, the age, and then the qualifiers, especially when it comes to the DSM questions. And you start looking at the bottom and saying, oh, it's trying to make me give a diagnosis. They're just using the common ones, which are the ones we went over tonight: adjustment disorder, bipolar. It's often going to be bipolar 1, but you got to know that you still need to know the difference between hypo versus hypo. You still got to know the difference between mania and manic. So, because the depression and the anxiety, all of that stuff looks alike. So remember, when you have anxiety, you still have generalized anxiety, separation anxiety. So this is one of those other sections where I can say you just have to memorize it, because in real life, you can always go back to your DSM-5. But in real life, also, you got to know the concepts, because sometimes, if you work in a hospital or something, you may be on Front Street where you got to give it at that moment. Mastermind, what did you get out of tonight's session? Uh-oh, did I lose? Okay. Nicole, what did you get out of tonight's session?
That OCPD is a person seeking perfection, and OCD disrupts their life, and that the disruptive mood dysregulation disorder is the diagnosis they use for children with what we would say is bipolar disorder. I did not realize that that was what it was.
I'm
A lot
going
of
to.
other stuff too, but
Yeah, those stuck out, and I'm glad it did. I have to do a presentation at a HBCU in Mississippi in a month or so, and I'm doing it on like the common disabilities for children. And believe it or not, one of them is autism spectrum, and it's I have to also talk about disruptive and bipolar, because a lot of times people are like, my child just wilding out, and so people have to know, you got to know the difference between oppositional defiant conduct disorder as well as antisocial. Why have you, Nicole? What is antisocial?
um, when the person, it's not so much that they don't want to socialize, but they are unapologetic about their behavior and they just kind of do whatever they want to do, and it doesn't matter how you feel about it. They just want to do what they want to do. And it can be, you can suffer because of it if you're a friend in their life.
Yep. And with them, with people with antisocial disorder, they they kill people. They kill cats. They hurt animals. So they have a disregard for rules. Nicole, you're making me think I'm going delusional.
Don't
I just,
don't do that.
I'm sorry. Y'all don't know. I go to sleep at 8 o'clock. And
Me
so
too.
you just
Me too.
fading away. I'm like, I'm getting delusional over here. Okay. Thank you, Nicole. Let's see. Hillary, tell us what you got out of tonight's session.
Well, I feel pretty comfortable with the main diagnosis. I feel comfortable with those, but I guess basically what I did get, the few notes I made, was the smaller things. I think I'm comfortable with schizophrenia, bipolar, the diagnosis, and all of that stuff. But it's the little things, even the catatonia. I mean, I know what it is, but I don't think about it. I don't study it. It's little things like that, and even the tics disorders and stuff. It's the smaller things that I don't ever think about sometimes, even the positives and the negatives with the schizophrenia. And I know positives is them having things they're not supposed to, that's added to them, and the negatives are things they should have that they don't. But I guess I don't ever think about those. I'm so stuck on the durations and symptoms till sometimes there are little things under there that I don't ever think to even study.
I hope this make you pay attention to it, because those ticks are showing up more on the exam. And so you just got to know it's a bodily thing that's going on, but you want to know, it's the difference between ticks and Tourette's. So it's important because it's showing up as well. Also, you all, I'm glad you said that too, Hillary, because Parkinson shows up a lot. I didn't go over that, and Parkinson is typically going to show up in an elderly individual. And that's when, again, they don't have control of mobility anymore. Parkinson also affects the brain, where a person wants, they can think, but they cannot articulate it all the way. And if you want to think about famous people with Parkinson, it would be like Michael J. Fox as well as Cassius Clay, which is Muhammad Ali. Asia, what
And
did you get?
Parkinson is a form of dementia.
It is, thank you. And it's one of those neuro. So remember, I told you those are different sections, and it's under neuro. Asia.
I would say I have a better understanding of the ego strength. Because that one I did see it a lot of my practice tests that I have been taking. So I have a better understanding of that, and I know that I need to slow down when I'm reading those questions. Like, yeah, I'm missing points because I'm just reading it so fast, just trying to rush through. So
Yep,
that's
take
what
your
I really
time.
taken. Yeah, I need to take my time.
Yeah. I will say I have several students on an individual level that's on group tonight. And one thing, I'm praising y'all without telling who y'all are, but They did what we've been talking about our individual sessions. I'm so happy, y'all. But they read their questions twice and they was pulling. I was over here like, yes, yes, yes. They was like, this is this, and this is this, and this and this. So those are things you do have to look for, those qualifiers as well as distractors. Because the distractors a lot of times can be in the beginning, and then when you get to the end, your brain and already said, oh, this is what the answer is. And so when you get to the qualifying stuff at the end of the vignette, your brain and already agree with the distractors. And so you pick an answer that matches the distractor. That's why we always say, oh, it looked like it can be two answers. It does, because it depends on, and midway in the test, our brain starts fading out. And that's why it's important to tell yourself, read the question 2 times, read it 2 times, and eliminate 2, even when there's only 3 choices. Miss Hunter.
Delirium is mostly medical. It can be reversed, whereas dementia is neurological and it's a disease. That's the best way I can remember to not mix those two up.
I'm glad you got it. Jess with the mess. You know, there's a girl named Jess with the mess, and she's a comedian.
No.
Jess, have you already done it?
The what?
Have you
The
already
test?
have you gave what you learned out of group tonight? You already spoke, haven't you? Okay.
Yeah.
Some people are jumping off my screen. Who did not speak? Cassandra is gone as well. Because y'all could have left. So you didn't have to. I'm actually way past your time. So I'm glad to hear that everyone got something out of tonight's session. This is one of the sessions I will tell you you can memorize. Also, when you're doing this section, DSM, you also need to be learning medications. They coincide with each other. So just keep that in mind when you're studying. You can go back and watch this video. I also suggest when you're looking at stuff from the DSM-5, you can Google and just ask for photos. Don't read the definitions, just Google and then go straight to images. So like if you say delusional versus delirium, you're going to Google delusional versus delirium and you're just going to look at the image. So that's something when you're studying that can help you, because again, sometimes our brain starts shutting down because a lot of us are missing this exam by 1 point. And so we start rationalizing it a little bit. And so having those pictures is just kind of resetting your mind. So I am not going to keep you all any longer. I'm glad you all got something out of tonight's session. And some of you all I will see again. I do know I'll be doing a group probably in 2 weeks, either 1 or 2 weeks. So Dr. Pam won't be available and I'll be back again. All righty then. Everybody have a good night.
Night.
Bye-bye.
You too. Good night.
Thank you. Good night.
All right. Master